Joining us back is Dr. Michelle Lofwall, and I'm going to turn it over to her to kind of go over some of our learning objectives for today.
Great. Thank you so much. It's wonderful to have so many of you back from last week. And if you missed last week, I would just encourage you to, it's on YouTube, I believe, right, John, and or will be soon. And you can review it at your leisure. It's all recorded, and you can also get, I think, credit for it too, right? Right, John? Am I saying the right thing?
Yes, so all our sessions are on YouTube the Monday following KY Open, and you're free to review those. If you would like a certificate of attendance for viewing those sessions, absolutely. And then we work to get those online to cecentral.com as well, where you can earn CE credit, but that's usually a little bit, we do that quarterly.
Yeah, so I just say that because a lot of the things that we're reviewing, like the references and all that, will be in that slide deck, but I'll try and remind folks of them, and maybe John or Chris, if you're on, you can always put them into the chat too, if people want to have access to them sooner. So we want to continue just to discuss and emphasize how important it is for us all to understand. We have so many people on this call that are part of the essential workforce for HEAL, doing care navigation and peer recovery support. We have got to improve the health literacy in our communities, and you're the key to doing that. And so understanding really that addiction is essential for us all to be able to explain, to screen for, to treat using evidence-based practices that we know decrease the risk of death and help improve the lives of individuals in their communities. So substance use disorder, we know, is often looked at as a moral failing and not as a medically treatable chronic illness. And that's what we're here really to change. And so we want to be able to identify the spectrum of substance use. We want to remind ourselves about the brain changes that are occurring in response to substance use and that are seen in substance use disorders. And we want to use accurate terminology so that we don't unconsciously stigmatize populations and decrease access to treatment. And so by the end of today, we really want to have you be more comfortable knowing what that appropriate clinical terminology is, using words like adding the word remission to your language, not just being familiar with recovery, but remission as well from a substance use disorder. We want to remind ourselves about the basic epidemiology and the public health impact of substance use disorders, and remind ourselves too that, this is just one thing. Many times, lots of people have other comorbidities that'll go along with this, and other important social determinants of health that really do impact access and whether or not you're going to live or die or have access or not to treatment. And describe how the chronic disease principles, how we can apply them to addiction treatment to have much, much better outcomes, and to try and help ourselves identify when there might be stigma or some unconscious bias at play. So we're just going to start with just a brief review and a polling question here. So what's the most common diagnosed substance use disorder in the United States among the list of substances here? Is it marijuana, opioids, alcohol, or methamphetamine? So we've got about 70% of you saying alcohol and about 30% saying opioids. So alcohol is the correct answer. So, and it's on the rise. It really has gone up substantially. And in part, it's, there's COVID related causes. I don't know if anybody's gone into a liquor store recently. Also, just to me, it's kind of remarkable how the marketing has changed for alcohol too. I didn't realize, how clearly it is actually marketing towards women now much more. As well as, just with some insinuation, like there's a whole brand that's called Fit Wine, like with a skinny woman on it, suggesting that you get thin maybe by drinking, or lots of other marketing that we've seen before that is very, very powerful. And was just on the phone with UK's transplant surgeon last week. He's looking for more assistance with substance use disorder among people he's transplanting the livers for. And he says that basically it used to be a few years ago, all the transplants for livers he was doing was for Hep C. And now, since we have cures for Hep C, that's, he's doing far fewer liver transplants for that, which is wonderful. It's exactly what we wanted to see with, having Hep C treatment and increasing access to that. Now, the vast majority of his liver transplants are for alcoholic liver disease. And this used to be about a 70-30 split between males and females, and it's now about a 50-50 split. So alcohol use disorder is really on the rise and affecting both males and females. So there obviously we have lots of other substance use disorders as well, but it's just important to keep that in mind as we are focusing on opiate use disorder, okay? Because lots of people with opiate use disorder are also going to have other substance use disorders. We see lots of methamphetamine with that, but we know that even our community estimate, so this is data from the annual survey by SAMHSA, the substance use, the National Survey on Drug Use and Health. It surveys community dwelling persons in their home age 12 years and older. And so there are about 2.5 million people with opioid use disorder in 2016 in this survey. And we know this is a gross underestimate. We think it's about at least double this. And unfortunately, there's only a few that are getting access to specialty treatment with FDA approved medication treatment. So about 20% of people with OUD, opioid use disorder, receive specialty addiction treatment for that. And among those, just a little over a third are receiving methadone, buprenorphine, or naltrexone. So we'll go to our next slide. Here's another question. So how do we define recovery? Is it a decrease in or disappearance of signs and symptoms of a disease? Is it a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential? Or is it C, abstinence achieved through medications for substance use disorder? It's unanimous. You guys got it. So that is right. That's what recovery is. And then I don't go on to the next. Okay, very good. You're good. Good. Go ahead. Go ahead, John. So key definitions. Remember the definition of stigma. It's a set of negative and often unfair beliefs that a society has against a group of people about something. And so recovery, and frequently we see stigma against people with opiate use disorder, substance use disorders, but also there's stigma about the treatments, like the FDA mortality reducing treatments. There's lots of stigma and misinformation about those. Recovery, just remember, you got that answer right, so I'm not going to hammer home on that. But I do want to emphasize this last sentence, that recovery is built on access to evidence-based clinical treatments and recovery support services for all populations. Okay, all populations. We know that we have seen across Kentucky a huge increase in opioid-involved overdose deaths for all races. But for African Americans, it is much, much higher. The increase is much, much higher than for any other race. So we've got to make sure that what we're doing across wave 2 is really aimed towards trying to decrease these these disparities. And reminding ourselves, right? How do we think that someone is ever going to get healthy after an injury or an illness if they don't have access to the treatment, right? Like someone breaks their leg and they need surgery and they need a crutch then for a while. Why do we think that they would possibly be able to recover without having access to medical services, right? So we know we have really, really strong evidence-based mortality reducing treatments for opiate use disorder. So just please remember this one key piece: recovery is built upon access to evidence-based clinical treatments. So I emphasize that because sometimes you'll hear the first part and then someone will say something really negative about treatment with methadone or buprenorphine or with naltrexone. and they'll poo-poo it. And then but you can say, hey, but you're pro-recovery. Did you, part of, recovery is having access to evidence-based medication treatments. So just trying to give you some language here for how you could respond to some things. Recovery and treatment are not the same thing, okay? But they are beautiful when they go together, okay? Like they are not meant to be separate. They are meant to be together. They are, and so we need to make sure our patients or our clients actually know what treatment options are available to them, so that way they have the best chance at having the recovery that they're looking for. This is our definition of substance use disorder. This is in the Diagnostic and Statistical Manual. We're in the 5th version. Remember, we said you can kind of, instead of trying not to memorize these things, just remember the 3 C's: compulsive use, continued use despite harmful consequences, and having that craving. If you can, and it's all about that substance use. So if you can remember the 3 C's, really all of these symptoms, signs and symptoms here fall into those categories. And then, we'll often hear someone say, well, addiction or substance use disorder, do they just have to stop, right? It's a behavior, so they just have to, to have enough willpower. And, that is true, that it is a behavior, but all of our behaviors, right, remember, are in our brain, what an individual does, and that the brain changes as behavior changes. Drug taking is a behavior, and as it continues under a variety of circumstances, the brain is learning all of these things, and it's creating new pathways in different areas of the brain. That are involved with learning and memory, and they're all in the unconscious areas of our brain. So that the reasons for continued use and response to drug changes include reward and motivation. These are all things that get really complicated and get ingrained in the brain, and the brain is changing. And so it is not as easy as just stopping. And so we talked about how we can view behavior as involving 3 different things. Choice. So what are the choices available to that person? And this in part is going to depend upon where you live. Okay. So what are the choices? If you don't use drugs, what are the other choices that are available to you in your community that might be helpful to do instead of using drugs? How has the conditioned learning gone on for that person through their life? What have they learned? This is, remember, like Pavlov's dogs and Skinner, all of that, psychology 101, if you took a class in that. And then the physiological drive. So we talked a little bit last week about how drug use, when you start to see those 3 C's, the compulsive use, the craving, and the continued use despite the harmful consequences, that you are now talking about the brain having changed and having developed an appetite for drugs that is very similar to sleep and to eating, where if you deny yourself sleep, you deny yourself food, that your brain automatically starts to crave it and will focus entirely upon getting that until it is achieved. And you will do some really, what looks like to an outsider is insane things if you do not get some sleep or you do not get food, right? We talked about how people can fall asleep while driving, how they fall asleep standing up, all of that. And so what the medicines do for opiate use disorder, specifically methadone and buprenorphine, is they are really dampening down that physiological drive. So that drive to use and is really being dampened down. So that way the person has a little bit more of an opportunity, I would say a lot more of an opportunity, to make some more conscious choices. And then part of our recovery support services and developing recovery capital helps have healthier choices available to them. So that way they can be also driven to choose something else while on the medication. And then the conditioned learning, if the person does have a slip, because that's very common, very few of us can ever, change something that's become habitual. Think about yourself. Maybe you've tried to quit smoking, or maybe you yourself have had a problem with a substance, and you want to change. It's very infrequent that you just make that decision and it goes away all at once. But while you're on the medicine, if all 3 of the medications that are FDA approved for opioid use disorder, if you slip, remember, you're blocked from dying because the medicine is on the receptors in the part of the brain that control breathing. And so you get to stay alive. And at the same time, the medicine is on the receptors in the brain that produce reward from the drug. So if you went and you used heroin or fentanyl while you were on any of the 3 FDA approved medications, it would have been a waste of money. And so that's how you can try and also change behavior. You're changing what is happening after someone uses. So that's the response, and that's part of conditioned learning. And we're trying to extinguish the drug taking behavior, and extinguishing takes a long time to do. The one thing that doesn't work is punishment. We know that punishment is a very ineffective way to change someone's choices in the long run. So we want to think of substance use disorder then as a compulsive behavior. It's a brain disease that it's expressed that way. Just because something is a behavior doesn't mean that it's under your own control. Think about a bunch of other behaviors that you have. How you got here today. Did you have to think consciously about every single key that you typed in your computer, or about the on-off switch on your phone, or however you got here today? You probably have done it so many times that you were able to kind of do it on autopilot. So that's behavior. That's proof to you that it's not so easy to just unlearn that kind of stuff. So remember the 3 C's, the persistent use despite harmful consequences, that craving, which is really a reflection of the behavior now having its own drive or appetite. And what was conscious, when you initially learned something, riding a bike, learning how to drive, the first time you used by the injection route, you'd be very, very conscious of every single step involved of all of those things. But then after you repeated it enough, your brain learned how to do it, and you didn't really have to think all that much about it anymore. And so we have lots of circuits that get involved in behaviors that become autopilot and that become rewarding too. And then treatment and recovery. So we are aiming for good quality treatment. We are not aiming for perfect. Perfect doesn't exist. We are aiming for good quality treatment, which involves an assessment for the need of recovery support services, as well as giving people the choices for what their treatment options are. Not everyone is going to need the full press of recovery support services to do well and to improve their health and to achieve abstinence. We want to use our resources in a logical way. This is usually done in a stepped care approach, okay, where you provide the things that you really think are going to save the person's life, and then you add things on top as needed. So remember, treatment and recovery are not the same, but they can and do often exist, and they should exist together, and people should have the choice of having them both exist together. And treatment can be for as long as the person needs. We are aiming to fulfill each person's potential. These are things that we should want for everyone with a chronic disease, those that have diabetes, chronic obstructive pulmonary disease, schizophrenia. Not, recovery is not a term that, needs to only be used with people with substance use disorder or mental illness. We have lots of endpoints that we're interested in. You're good. Okay. So here's a question. So last week, the American Disabilities Act was mentioned. What is it and how does it apply to substance use disorder? So that's a great question. And there is a great article, and Chris or John, maybe you can just put the link to the article in here. It's by Sinkman and Durchak. And it talks about, like, the title is something like how the ADA can help decrease opioid involved overdose deaths. And so I am not a lawyer, so you're going to have to put up with me if I don't give you the exact definition of the Americans for Disability Act. But what it does for people with substance use disorder and for opiate use disorder specifically is that if I, as a doctor, have a patient who I am prescribing methadone or buprenorphine or Vivitrol, and they then, excuse me, go into, like, let's say they get picked up on an old warrant or and go to jail, they should have access to those medications. It would be very likely, and I can't say for sure, but I believe that it is very, very likely that if the jail medical provider was to refuse to provide continued access to those medications that were being prescribed for a legitimate medical illness by a legitimate licensed physician, that is an example of a violation of the Americans for Disabilities Act. And so this is one of the things that is mentioned in the Sinkman and Dorchak article, and that there's it happens way too often. And what we frequently hear from the jail medical provider is that we just don't do that. And I just don't think that is an adequate excuse anymore, because what ends up happening in this case is that the person is then forced to go through withdrawal from those medicines that have opioid agonist properties. In doing that, they are feeling incredibly sick, physically and mentally. They are simultaneously losing tolerance. When they then leave, they are not given a prescription from the jail. And then they frequently are going to go out and have a slip to use. And that is frequently deadly, because they use what they had used often, what they'd used when they were actively addicted. And patients, or don't understand this concept of the loss of tolerance, and then they die. And this does not need to happen. Opioid use disorder is really different in this way compared to alcohol use disorder, cocaine use disorder, methamphetamine. A single slip back to alcohol, methamphetamine, or cocaine is not likely to kill someone. It can, of course, someone can have alcohol poisoning and drink so much that they kill themselves from a single episode of acute intoxication. It's possible it could happen with a stimulant, that you have a massive heart attack or have a fatal arrhythmia, but it is just much less common than now when you go back and you have a slip, especially given that there is so much fentanyl and carfentanil that's just so highly potent. And so, the medicines for opiate use disorder treatment, these are FDA approved, they're legitimate, and they save people's lives. Like, there's no ifs, ands, or buts about it. And so it's this case, like when someone is basically being forced to come off, that is violating the Americans for Disabilities Act. So you can't discriminate against someone for being on medication. Okay, now if the person, like, let's say, let's say your employer, right? And you do, and part of your job is that you do get randomly tested for substances. And so you get called in, you get tested for an illicit substance, then you can be discriminated for using illicit substances. And you could say, well, I have an alcohol use disorder, or I have an opioid use disorder. That's not a legitimate excuse, okay? But if you tested positive for buprenorphine and you were prescribed buprenorphine, you say, look, I'm being prescribed buprenorphine, like, this is why it's in there. It's, and and this is all true. And you have a medical provider and all that, like, they cannot discriminate against you for that. So I hope this makes sense. But I really think that the article does a great job explaining it, and that there's an increasing push, really with this within the criminal justice system of getting jails and prisons to do this. Lisa puts in the chat, would jails deny heart meds for a patient with heart problems? Probably not, because of the liability. Has there been arguments about being denied MOUD medications, then overdosing and holding the jail liable? Yes, so there are some examples in the Sinkman and Durchak of cases that have been brought against, and using the ADA as the rationale for why that discrimination shouldn't be happening. And so I think, yes, Lisa, this is starting to happen. And I think that we're starting to see in Kentucky something really exciting in Jefferson County with I think the Moore Clinic is a OTP that's now trying to really vamp up services to Louisville Metro. So I think that is a really exciting thing that's starting to happen, and we hope that will catch on across our entire state. There are 4 states now that have laws at the state level that are requiring, I believe, their jails and prisons to provide access to all 3 MOUDs upon entry. And there are, jail medical providers, prison medical providers, and they do provide, they're supposed to be there to provide medical services. So lots of people, I think, also, pointing out that people being denied medical treatment. Shirley's putting that in, saying because she was taking Suboxone, which makes no sense. That's not something that we want happening. And I think it contributes to poor outcomes for sure. So, and a lot of suffering.
Okay. I've had 2 employers in the past dismiss me solely for being on MOUD, probably 5 years ago, 7 years ago. And I was wondering, do you think that, it isn't a law now. I don't think that you can't dismiss someone for being on MOUD from employment or a program, say, but do you think that it will be, or do you know if there are any people that are starting to put that in or into it, or I can't think of the word. I'm so sorry.
No, that's okay.
Go ahead.
No, so part of like the ADA is that you're not supposed to be able to discriminate against someone for using legitimately prescribed medical treatment for a medical illness. And that's been there for a long time. I think that these things happen, but these would be examples of, like potential violations of the ADA. So SAMHSA also has a pamphlet that's meant for like patients and the lay public about, about the ADA, what you should know. Maybe we can put that into the link too for you. But, if this is something that's happening, you can always refer your clients to like the ACLU, or if you have, talk about it with your supervisor. Remember, the HEAL has policy questions. So if you think there's a policy question, there's that mechanism for putting that policy question into the HEAL team. HEAL does not have the ability to lobby for policy change, but we do have the ability to like get more information and make sure that all of our coalitions and communities kind of understand the existing policies that exist. How can non-medical professionals assist in a diagnosis of substance use disorder? So this is a good question. So if you're not a medical professional, then you won't be able to make the diagnosis of a substance use disorder. But as a non-medical person, you can be educated about what the signs and symptoms still are, right? And so you've learned about the 3 C's, and you could say, look, it sounds like you're having a lot of cravings, you're trying to stop and you're not able to, I've learned that this isn't, a character flaw, you keep blaming yourself or whatever it is that, the person is saying and says, I've learned that this is a real brain disorder and that there's treatment available. Can I help you? Are you interested in getting an assessment? And, see if you can get some help. That would be something that you could do to help. And certainly if you are, working in linkage, then sign that person up for the linkage program, share, the community resource guide, and, see if you can link them to MOUD after you explain what the treatment options may be if this is a person who's using opioids, right? I mean, we're really lucky with opiate use disorder in comparison to like cocaine and methamphetamine, because the three medications that we have are so helpful, especially the partial and full agonist one, because they so substantially decreased cravings. They decrease that physiological drive to use, and people are willing to take them. So that is a huge plus. And so they're really making sure that people appreciate that is a huge thing that you can do. Do people, I mean, I think that a lot of the people in this group have had experience probably trying to help people that aren't yet in treatment. Does anybody want to share something like that they have found is helpful, like to get someone to consider that they might have a substance use disorder or an opiate use disorder specifically?
I've just asked basic questions to them, like, is your life out of control? How are your relationships? To kind of get them on the track of seeing that maybe their addiction is a problem. Because sometimes people don't realize, I didn't know that I was a drug addict for years, and that's crazy to say, but until I sat down and realized that my life was out of control, I'm going in and out of jail, things are not, the perception we have in addiction is that we've got control of this, but in reality, we're completely out of control and things are falling apart. So just real basic questions sometimes turns that light on for them that maybe they have an issue.
Great suggestion. Thanks for sharing that. Anyone else with suggestions here? Because we learn from each other too. So that's another big part of the whole purpose of the Q&A sessions. And John's right. John says, it sounds like you're using motivational interviewing, Shirley. Yes.
I was, and
you were, yes.
I had a whole semester on it. So I love it in college. So that's one of my favorite things to use is motivational interviewing.
It's really helpful. And we will be having some workshops on motivational interviewing in November. Okay, let's go to our next question. So once a person is diagnosed with substance use disorder, what treatment options are available? So is it okay if I just make this about opiate use disorder since that's the focus? John, or was there like an intention here to talk about something besides opioids?
I don't think so. I think it was general, so.
Okay. So with opiate use disorder, the treatment options that are available, I would say like go back to that MOUD flyer that the HEAL has, the two-sided flyer that tells people, reminds people of the key facts about opiate use disorder, about remission, recovery, explains the, opioids, how they work in the brain, why medication treatment helps decrease death, why it helps decrease relapse, what each medicine is like, right? Like where people get it, how they take it, is it by mouth? Is it an injection? Do they have to go every day to the clinic, which is the methadone treatment option is, when you start on methadone treatment, you do need to go every day for supervised dosing. And then you get to go less frequently over time, but it takes a long time to build up like substantial take home medication to take on your own, not under supervision. In contrast, buprenorphine, you can get outside of that with more, at-home taking of the medicine. And then there's a monthly injection of buprenorphine that you can take as well that goes in the belly. And all of this is meant to be going with an individualized assessment. So to determine if the person has other substance use disorders as well, like a tobacco use disorder or a stimulant use disorder, or if they have major depression or bipolar disorder or an anxiety disorder. And then what their recovery support needs are. Does the person have stable housing? Do they have adequate food security? Do they have adequate transportation? And we can help those people with those recovery support needs using the HEAL barrier relief funds, right? For that involve assistance with like housing and transportation and all of those things that are really essential for people to have in order to be successful in treatment and in their recovery. So you want to have that individualized assessment as well. And then, just the other thing that I like to tell people, it's like, sometimes there's no way for us to tell which of the 3 medicines is going to be the one that's going to work best for someone. It's really, once they have the information, then they make, the most informed choice that they can. It's not signing a contract though, like in blood, they can always change their mind. I've had patients on all 3 different medications at different times based upon what their needs were at the time. And, that's similar to other chronic illnesses too. Like you're not always on the same diabetes medicine for your whole life. The one you start on, it may not be the same one you're on in 2 months or 3 months or a year or 3 years from now. So just trying to always bring yourself back to, maybe a chronic illness that you feel more comfortable talking about. If this is new to you, thinking about substance use disorder as a chronic illness. So if it's easier for you to think about diabetes or congestive heart failure or chronic obstructive pulmonary disease, or maybe someone that that has rheumatoid arthritis or bipolar disorder or schizophrenia, kind of just thinking about what treatment has looked like for that person, right? Maybe they needed to be inpatient sometimes because their illness was exacerbated. Maybe they had to go outpatient and go frequently for a while. Maybe then they were stable for a year or so, and then they became unstable, so there's not just one way that things go. We need to look at each person individually and what their needs are. But just knowing that we do have these 3 life-saving treatments, if the person wants to take them, that we really want to make those available. Because really what's happening now is like we have these 2 medicines, methadone and buprenorphine specifically, that decrease your risk of death by more than 50%. And we have so few people that even know that and are choosing to take it. And so that would be like, having something that treats lung cancer, breast cancer, prostate cancer, decreases the risk of death, and them not getting that treatment. Like that would be unheard of, only having, like 10% or 20% of people getting a mortality reducing cancer treatment. So, and John put a link to the MOUD flyer there too, if anyone isn't familiar with that. I know all of our peers and care navigators probably are tired of me talking about the MOUD flyer.
I had a question that came in related to this, and it said, why have the recommendations for MOUD changed for them as short-term medications to possibly lifelong medications?
What's the question?
So I think initially MOUD was short-term medication, but now it's possibly, the recommendation is lifelong or possibly lifelong. So how did that, or why did that change come about where,
Yeah, because we kept, so like in like the 1930s, when the Public Health Service thought that they were going to be able to cure addiction, and they opened up the Lexington Narcotics Farm, right off Newtown Pike. And then there was another hospital that they opened in Texas. So these are both hospitals, even though they called the one in Lexington, the Lexington Narcotics Farm. They later changed the name after there were too many jokes about where do you grow the narcotics. And what they found, well, what they did was they basically took people from across the country that were getting charges basically for drug possession, nonviolent drug offenses, and they gave them the option, instead of going like to jail, to go to the Lexington Narcotics Farm for the quote Lexington cure. And this was basically the beginning of the intramural program of the National Institute on Drug Abuse. This is where methadone was being studied to see if it could help as a treatment for opiate use disorder. So there was a lot of morphine addiction at this time in the country. And they gave people therapy, they gave them vocational therapy, they gave them some medicine, and then some people stayed for like well over a year, and then they sent them back home without any ongoing treatment. Like if they had been on methadone, the methadone would have stopped. And what they found was that over 80% of people relapsed when they went back home. So indicating that there was, a need for ongoing treatment, and that this isn't like an acute appendicitis or something that you really cure and you're done with. So this is really part of the reason why we want all of our communities to have access to mental and behavioral health treatment, is we need to have treatment where people live, and it needs to be for as long as people need. So there have been many other National Institute of Health sponsored trials with people addicted to heroin, people addicted to prescription opioids. And the results are basically the same study after study after study, is that when you remove the medication, that the most common outcome is that people relapse. And there was one study that was, I think it was done in Sweden, where they had very tight regulations around accessing treatment. And that study actually showed a statistically significant increase in death with people who were forced to detox off of their medication. And then in the United States, we just have so many trials basically showing the same thing, that people just return to use after they're forced to go off their medication. And so, and given that we know also, like with the advances in brain, like PET imaging and all the different types of fancy brain scans that we could do, we can see that the brain has changed. And so the Surgeon General's report a few years ago was really focused entirely on addiction in the United States, not just opiate use disorder, but they showed, there's a whole chapter in there about the changes in the brain that was trying to educate the public about how the brain does change with addiction. And given all the studies over many, many decades now in this, it's really the best to think about this as a chronic relapsing illness. And there are, while I said that 80% of people are going to relapse, that means 20% don't. So you could say, well, you're wrong. There's some people that don't. And so you could say, great, we just don't know. We don't have a way to predict which people are those 20%. So, if you have someone that wants to try to come off their medication and that's their choice, then we work with those folks, but we keep the eye on the big picture, which is that they, are maintaining all the gains that they've made in treatment, right? That we hope that they now have a sense of purpose in life, that they have stable housing, that they have a job, or they have something else that is meaningful to them if they're a caregiver or volunteering somewhere, and that they have a sense of agency over their health and wellness, and that they have a social network of people that don't use drugs. And that's what we want. And we want to keep them alive, and we don't want them to have consequences of untreated substance use disorder, which, are hepatitis C and HIV and, public safety outcomes, because people who have active addiction frequently are committing property crime. And that's another outcome that's been demonstrated to decrease when people are on methadone and buprenorphine. You have less property crime. So that is why the recommendations have changed, is just because the weight of the science has just drastically increased. And, you know, in the 1930s, we just didn't have any medication that was effective to treat it. It wasn't until 1960 that methadone really became available to treat opiate addiction.
I personally have a follow-up question, if that's okay.
Of course.
Have there been studies on like the 20% that do follow-up studies that look at the people that successfully have, abstained from abstained, after they've gone off their treatment? I'm just curious.
Yeah, there are some of those studies. And then, so it's all about, how long you have to follow people, right? Like how much funding can you get to follow people over time? And so, those studies that are 20, when I'm saying 20%, you have to look at how long was the follow-up of that for. There's one study that I'm remembering that's called the POTE study. It's the Prescription Opioid Addiction Treatment Study, I believe is what it stands for. And that study looked at people who I think had not relapsed, and then followed them for a little longer. And then, some of them did end up having slips, and then they offered them kind of treatment again, because the idea was, how many treatment episodes would someone need, in a way? Like, is there some sort of magic number? But it's just not entirely clear. There's so many different factors, I think, that come up in people's lives, and it's super, super complicated. Like, it's a complex illness that's, it's about 50% genetic, 50% environment. And so, we see rates of addiction go up as different drug supplies become available. So sometimes, the answers change depending upon what's going on in the environment, right? And then that includes things that are happening with policies too, right? So I don't really have a simple answer. It's a really good question. And
I think I found the paper, so I'll look at it myself. So thank you.
okay. I would say the other thing that's really hard to answer your question is that a lot of people, when they do go into remission, is they will tell me they just want to change the channel. Like they don't want to talk about it anymore. They don't want it to be identified as that. And they don't really necessarily want to participate in ongoing research. They just want to be kind of like done and be living their lives. So it's a difficult population to reach.
Sure.
Okay, besides opioids, what other substances are seeing a rise in use? So I think our group here can tell us this. What are you all seeing in your communities besides, the fentanyl?
I'm in Boyd County, and we're seeing a extremely high rise of methamphetamine.
Yeah,
it's to the point that the hospital is building a brand new emergency room. I think it's like 800 beds, and 400 of them are just for they call it mental health. They're treating everyone down here as they have mental health problems, but it's truly methamphetamine. These people are coming in the ER that haven't slept in days, that are on methamphetamine. So it's a battle here with them, with the hospital. I mean, it just, they don't see it as a disease. They don't, it's been tough.
mm-hmm. I think methamphetamine's a big problem across Kentucky, and it does make it really, really hard. It complicates the treatment for sure. And then I think part of the problem that you might be seeing with the hospitals is that most insurances will not approve inpatient hospitalization only for a substance use disorder. So sometimes it's, it's not that the hospital providers don't want to help the person, but sometimes it becomes a limitation of the payers of the health insurance. Yeah, so seeing a lot of Eastern Kentucky talking about methamphetamine and heroin, and Clark County seeing an increase in cocaine. Okay. That's good to know, Tasha.
If I may just speak directly instead of the chat. I'm a parent. I live in Fayette County, and I'm a parent. And I have my daughter's in college, started as a freshman, and I have a son as a sophomore. But I've seen a lot of parents who certainly have concerns about your children with alcohol and maybe marijuana, but over the past few years, the number of parents that are really starting to stress, be concerned about fentanyl and its the rapid rate it's being introduced into communities. And so going from something that a person is just trying something to experiment to, 0 to 100, where could be a fatal overdose in a heartbeat. So there are a lot of parents who had never really considered this that are really challenged by finding information about it and looking for resources to share with their families beyond, just working with family members who might be in recovery. But from a parent standpoint, it's very concerning, the fentanyl issue.
Absolutely. And so let's put into the chat the fentanyl flyer for everyone. We had our pharmacist make a flyer all about fentanyl. I also have a son in college and a daughter in high school, and very concerned about fentanyl too. Lots of kids in college use stimulants to, like ADHD type medications that they get from, friends or someone else, not prescribed to them, like Ritalin, Adderall. And I think the really scary thing is that a lot of, is that if it's not prescribed to them for legitimate ADHD and they're getting it from someone else, that it's quite possible that that is not actually Ritalin or Concerta. It could be stamped and made exactly to look like it, but it actually could be fentanyl. And so I have the conversation with my kids, and I've had conversations with friends and who are also parents and stuff. And I've recommended to them that they, just talk very openly to their kids about this fact, that even if they think they're getting a pill from someone else or a pill at a party, and it looks, someone's like swears up and down that it is, it's just an Adderall or it's just a whatever, that it could be fentanyl. There's just no way that they know. There's pictures online that you can show your kids or share, like where, I think it was like one of the first to have pictures was like the San Francisco Public Health Department, or maybe it was even a DEA website that shows what the real pill looks like and then what the stamped pill looks like that's actually fentanyl. And they are like almost 100% identical. You would have to almost be having like a microscope to really tell the difference, and just sharing that information. So, and then the other thing is just, get your kids a box of Narcan. My son has it, and I need to get one for my daughter, and you just kind of carry it with you. Doesn't mean that you carry a diagnosis or anything. It's just, I think it's a different time, and it's very scary. And I think that it also helps get the point across to our teenagers and young adults that their brains are not fully developed, and their brains are not fully developed in the area that is, says no to things, right? The whole prefrontal cortex, their ability to put the brakes on things. And so, yeah. And so, Brian, you're saying rainbow is being reported as very alluring. I don't know what rainbow is.
Yeah, it's manufactured, and it looks like candy. It's not, I think it's more chalk-like, not like a Skittles. I'm not certain, but it's it's one of those deceptive looking treats that could be instantaneously fatal. So there's the issue of, yes, having Narcan, of course, but also being in a situation, not to take it too many far off the track, but I had friends who lived in Colorado with young adults and children when marijuana was legalized, and then children were finding these gummies and things that looked just like candy and marketed to look like candy, almost indistinguishable in the package. And so kids were taking major doses of marijuana and were having severe reactions. But yeah, yes, rainbow is colorful fentanyl, so it's frightening.
Absolutely. Thank you. Yeah, and Nick's saying, Nick, do you just want to come off and talk?
Yeah, I had a friend of mine recently, maybe 2 or 3 months ago, sent me a photo of a positive fentanyl test strip next to a stamped pill that looked just like Adderall. So, I mean, I guess I kind of laughed, maybe not laughed at it, but it just kind of was like, yeah, right, before, especially for Adderall, because I've heard of, fake Xanax bars or something having fentanyl in them, but I never thought that anybody would even think to do that.
Yeah, it's very scary. I think it's very scary to be a parent raising children and adolescents and young adults. And I do think that it's part of why the overdose rates are really continuing to rise too, that there's a wealth of a variety of different people who are dying, people who have opiate use disorder and those who don't and never even intended to be using an opioid, right? So it's important that we're, sharing all this information with our communities.
I was just going to say that also I've seen a rise in Madison County and of fentanyl laced marijuana. And so I have a 16-year-old that's in high school, and I went ahead and trained her on Narcan, and she carries a single dose with her in her backpack to school every day. We just because high school, I think that population altogether, I know experiences more alcohol and more like marijuana usage to start with. So just in case somebody's smoking, which shouldn't be at school, but in case they are or something and they come across it, I've at least taught her how to respond appropriately. So that's another one, is the marijuana laced.
Yes, we've heard reports of that too. So that's a really good point. So I know we're a little over an hour. Anyone else with any questions that they want to ask or parting comments or?
I have a question. This is Shirley. This is the definitions I've worked in this field for a lot of years off and on, and your definitions of recovery and remission. Can you just kind of give me a brief summary of that? Because that's new language to me. It's always been either you're using or you're in recovery in the past. So I really like that, but I'm not sure how to explain that.
Sure. So there's SAMHSA's definition. So the Substance Abuse and Mental Health Services Administration. So that's where we got them from. And we can provide a larger link to that. I know if John or Chris, if you can just Google right away, the Google SAMHSA recovery definition, it should come up. And that might be really helpful for you to have and share with other people too. I mean, one of the things about being in recovery is that there's not a requirement for complete abstinence. Some people, there was a survey done a while back, because it's a process of change, right? And so it's not possible for everyone to be abstinent. And some people, a lot of my patients are like, there's no way, I want to be off opioids, but I'm not stopping marijuana. And we still offer them recovery support services. They still consider themselves to be in recovery. They have goals that are aligned with, you know, the definition of recovery. And I will certainly, you know, be talking to them about the other illicit substance, because I don't want them to get in trouble and get in jail. And there, you know, there is real addiction to marijuana, and it doesn't help the brain at all. But they can, I think it's really critical to appreciate that the definition of recovery does not have a requirement for abstinence. If the person wants to be in recovery, they get to say that about themselves and start that process of change. But yes, I think we've really emphasized the definitions in HEAL because we think that people were kind of making them up and not using validated resources when talking about them, and that the definitions that they were used were really kind of loaded with stigma. And I love that someone has a 10-year-old that knows how to administer Narcan. I mean, it is, it's unfortunate that a lot of parents pass away and, you know, it's sad to think that a child could potentially save a parent's life, but if there's an opportunity to do that, then that is an amazing thing.
Can I ask a question real quick?
Yes.
Okay, I was wondering if you are familiar with or might speak to the use of psilocybin. It's been in the news a little bit lately for treatment of alcoholism, and some research has been done on treating opioid use disorders with it. Are you familiar with it, and what do you think the future might look like with regard to that?
I'm not going to bet on it or invest in it. I don't know if you've seen any of the other, you know, any of the other studies that are involving ecstasy and some other controlled substances for other kind of mental health and substance use disorder indications. But there was a study or series of studies in Canada that just got shut down that were involving ecstasy, and was pretty alarming what was happening in those studies. And so you could easily Google and find some of the really good reporting about that. And so I think the devil's always in the details for all of these things. And a lot of the details include like the study population. The initial psilocybin study that kind of got things off and going again was done at Johns Hopkins a little over 10 years ago. And it was done in a highly controlled manner for people who were kind of like at the end of life and who did not have a history of any real substance use disorder. So I think these are really pretty early. And I think what we're seeing with some of the other psychedelic and ecstasy is really alarming. And, you know, basically the Canadian government shut it down. So I don't think it's hitting mainstay medicine. And I think if it ever does get approved, it's going to be incredibly heavily regulated, I would think, by the FDA, given how they've, you know, they're in the FDA's interest is in public health safety, like, and efficacy. And there will be a lot of safety issues, I think. So
Thank you.
Yeah.